We are going live in 10 seconds. 6. So we are live now.
Okay. Hello, everyone, and a very good evening. Uh, Thank you for joining us on today's webinar. My name is Viraj Lavingia. I'm a medical oncologist in GI services at HCG Cancer Center, Ahmedabad. And I welcome you all for today's live webinar on expert peer exchange on advanced HCC. First of all, I would like to introduce to you our expert faculty from USA, Dr. Amit Singhal, who is a medical director, liver transplant program at UT Southwest Center. So there is no talk or a lecture in this webinar. It's just a 1 hour of panel discussion. And I would like to introduce our eminent panelists. The first and foremost, Padma Shri Dr. A.S. Soin, Chairman and Chief of Liver Transplant Unit at Gurgaon, India, Medanta Institute. Dr. Soin is a surgeon and a pioneer in the field of liver transplant. Dr. Soin was awarded the Padma Shri by the President of India for his contribution to the field of medicine in 2010. We also have Dr. Hitesh Chawda, Director and Chief of GI Surgery and Division of Hepatobiliary Surgery at Sterling Hospital, Ahmedabad. We have Dr. Vimal Someshwar. He is a head of radiology and interventional radiology at Kokilaben Hospital, Mumbai. And then we have three of my colleagues, medical oncologists, Dr. Anant Ramaswamy, senior consultant medical oncologist in GI division at Tata Memorial, Mumbai. We have Dr. Vamshi Krishna, who is a senior consultant medical oncology at Apollo Hospital, Hyderabad. And then we have Dr. Bowman Dhabar, my guru and teacher, a senior consultant medical oncologist from Fortis and Jaslok, Mumbai. So this panel discussion will be moderated by none other than Dr. Senthil Rajappa, whom I don't think he needs any introduction, but he's a senior medical oncologist from Baswatarkam Indo-American Cancer Institute, Hyderabad. Now we'll be running a live Q&A throughout the webinar, and at the end of webinar, we'll be taking the questions. So we have embedded ask a question feature in our live web page. So if you have any questions, just pop them in. And if you miss anything, don't worry. We'll be sending you on-demand recording when it is available. So without further ado, let me welcome you all again. And for those of you who joined late, good evening again. Let us start the webinar. Senthil sir, the screen is all yours, sir.
Thank you, Viraj. I think Ravindra has to enable screen sharing. Ravindra, can you hear me? Viraj, can you give me a call, or if he's not around? Is he around?
Ravindra, screen share.
Yeah, finally he has, yes. All right, so that seems to be a new way of connecting. So Viraj, first time somebody told me the screen is all yours. They always say the stage is yours. And for the first time, I'm hearing somebody saying that the screen is yours. Anyway, great new way of greeting and handing over things to the host. Thank you so much. And welcome all panelists. I'm very humbled to be here in front of all of you today to moderate this panel discussion. A disclaimer is that I'm not a liver medical oncologist, so I do all solid tumors. So if because of my ignorance, I miss something in my presentation, or I make an inadvertent comment, please take the liberty of correcting me, because it's a learning experience for me also. So what we'll do in the course of this 1 hour is try to discuss 2 or 3 cases, which will start from early liver cancer, because we have some very senior experienced surgeons with us, and then go on, of course, to discuss the medical oncology issues that are part of this disease itself. Okay, let's start with this case. Here is a 46-year-old who was incidentally on a master health checkup detected to have a liver mass. His performance status is 0, and there are no comorbidities at all. His hepatitis profile was negative. His alpha fetoprotein was 436. He had a 3-centimeter lesion in the right lobe of his liver, absolutely asymptomatic at all. So, Dr. Soin, I want to start with you. The question is, how is it that people really who are not on a master health check picked up? We talk of those BCLC stage 0 tumors. I am yet to see one. I'm sure you are seeing many of them. So how is it that we really catch them? What is the role of surveillance in patients who have chronic liver disease?
So you have answered the question within your question.
Okay, great.
Yes. So all patients who have known chronic liver disease or known hepatitis B or hepatitis C, or unfortunately have been abusing alcohol for more than 10 years, or who have diabetes for over 10 years, they're all sitting ducks, might I say, for developing chronic liver disease and subsequently liver cancer. So any patients with any of the known history that I just said should be screened with alpha fetoprotein and ultrasound, and I believe CT scan as well. Now, the frequency is obviously not settled. It depends on what guidelines you're looking at. And of course, there are always personal preferences here. But I would do with a known chronic liver disease, I would do alpha fetoprotein and ultrasound of the abdomen every 3 months, and a CT scan 6 months to 12 months, depending on the extent of cirrhosis, the other history. I mean, for example, if there is alcohol and chronic hepatitis B, then you've got a increase in incidence, in which case you would do a 6-monthly CT scan. Otherwise, a yearly CT scan is okay.
Dr. Amit, I'm sure you have a properly organized program in your center for patients like this. What is your take on that? Do you agree with the frequency and the tests enumerated by Dr. Soin?
Yeah, so in our center, we typically, largely restrict surveillance to patients with cirrhosis from any etiology, as well as subgroups of patients with hepatitis B. And those subgroups of hepatitis B are typically male over the age of 40, female over the age of 50, family history of HCC, or if somebody's from Africa, then we do it at a younger age, somewhere in the 20s to 30s. But really, in terms of the etiologies, Dr. Soin has really hit upon them in terms of the etiologies of cirrhosis, whether it's viral hepatitis, alcohol, and then of course the most rapidly increasing commonly cause is non-alcoholic steatohepatitis, or now metabolic associated fatty liver disease, which we're all seeing much more frequently than we used to. These patients all have a very high incidence rate of HCC, somewhere between 2 to 5% per year. And so we know that HCC surveillance is cost effective in these patients. We typically follow the American and the European guidelines in our center. And so we do ultrasound plus minus alpha fetoprotein every 6 months. And that has been associated with significantly improved early detection, curative treatment receipt, and overall survival. Like Dr. Soin said, there is some interest in terms of using cross-sectional imaging, whether that's CT or MRI intermittently in these patients. Probably the highest level data to support that practice comes from the PRIA study, a study out of Korea, showing that you can actually use MRI about every 6 months and actually improve early detection. Although right now there's still concerns about cost, et cetera. So we typically restrict our testing to ultrasound and AFP every 6 months.
Right. So I think the point is that anybody with chronic liver disease should be going through some screening. Ultrasound plus minus AFP seems to be standard, but depending on the patient and the setup, it's perfectly all right to add a CT or an MR depending on what that predisposing factor is likely to be. So Dr. Hitesh, once you have a suspicion of a hepatocellular carcinoma on the ultrasound with an AFP that's going up, what would be your choice of imaging in order to delineate all the factors that will be necessary to take a decision on surgery versus locally ablative therapies for this patient?
So usually we do a triphasic CT scan as per our protocol. The other thing that we can do is an MRI. That depends from center to center. So usually what we do is we do a triphasic CT scan, try to see the characteristic of the HCC. We see for the size, extent of tumor, vascular invasion, any spread, etc. on CT. And according to the characteristic, we take it on forward.
Okay, so the basic is an MRI, contrast, or a triple phase CT.
Yeah,
I think those would be the basic minimum. Dr. Soin, I'm sure you must be having some experience with contrast and as ultrasound. So what is your thought on that? Does it offer any advantage, or it's complementary? What is it that your take is on?
So I agree with Hitesh that the preferred scanning technique with us is also a triphasic CT scan. And in fact, with the earlier reference to the Korean study about MRI, it must be said that in the same study, they found that the degree of false positives and false negatives with ultrasound was way too high.
Okay.
So it's not very reliable, ultrasound itself. But then, screening is screening. In terms of contrast enhanced ultrasound, we don't have that much experience in using it for screening cancer. We do have it available within our institute, and we use it in the post-transplant situation sometimes. And we have heard a couple of talks by them of some studies that they've done, the radiology departments have done, but we don't routinely use it. But yes, it enhances the sensitivity. It enhances the pickup rate of cancers which are smaller than 4 centimeters in our experience.
Right. Dr. Hitesh, you wanted to make a point.
No.
Actually, I would just add to that, being a radiologist, what happens is, let's say ultrasound has picked up a nodule and you don't know whether it's a regenerating nodule or a tumor. That's where the challenge comes in, and these are usually very small. And if at that early stage you want to pick it up, probably MR contrast is more sensitive to kind of identify. Once the tumor becomes big, 2.5, 3 centimeters, then CT triphasic, nowadays with perfusion scan, has added more value and has given more kind of histological diagnosis that this is HCC. So triphasic CT with perfusion probably is a choice that we have today. So if your CT scanner can take it, I think that's a way to go for these cases where there's a doubt.
Yeah.
So for the very small tumors, you're saying MRI contrast would be better.
Yes.
And as the size keeps going up, then the difference between MRI contrast versus a triphasic plus minus diffusion does not make a big difference.
That's right. That's right.
Right. So Dr. Amit, let me bring you in here again.
Yeah.
So there was a time when we used to say that characteristic features on the imaging plus an AFP that is elevated would clinch the diagnosis of a hepatocellular carcinoma. Does the value of AFP remain the same today, or a characteristic radiology is good enough to make a diagnosis, or the AFP is required to make a diagnosis? What is your thought on that?
Yeah, I'll just share a couple thoughts. The first, to answer your question, AFP has been taken out of the diagnostic algorithm now. So
Correct.
really, if you have a characteristic imaging, with arterial enhancement and delayed washout, capsule appearance, then that's sufficient to make a diagnosis in the correct setting, i.e. patients with underlying cirrhosis or chronic hepatitis B. You don't need to have an elevated AFP, and actually a large proportion of HCCs will have a normal AFP, and that should not dissuade you from the diagnosis.
Absolutely.
And similarly, you don't need to do a biopsy in those cases. The imaging has a positive predictive value somewhere between 95 to 97% in the correct setting. In terms of the second point, going back to your other question about contrast enhanced ultrasound, I'll just share quickly our experience, how we've incorporated this into our practice. So Dr. Soin, I know you brought up the fact that there are false positives on the ultrasound. And so what we've done in our practice is to incorporate contrast enhanced ultrasound as a reflex the same day that a patient has an ultrasound. So if they have a lesion on the ultrasound, they then get the contrast enhanced ultrasound before they leave. So we know if it's a false positive or if it's something that is concerning for HCC. Now, of course, the benefit of contrast enhanced ultrasound is it helps diagnose that individual lesion. And I think we're finding that the value of contrast enhanced ultrasound, or the accuracy of contrast enhanced ultrasound, is higher than reported previously. We're getting better at distinguishing cholangio and HCC on a CEUS. the one thing that contrast enhanced ultrasound doesn't do is it doesn't give you the other advantages of cross-sectional imaging. It doesn't actually stage the patient. So it doesn't rule out other lesions. And so what we will do is we'll do the contrast enhanced ultrasound when they leave, and then our first test is an MRI. In part because we find a lot of smaller tumors, and so we do think that the accuracy of MRI at that smaller stage is a little bit higher. And so we typically will then get the MRI to further characterize any other lesions in the liver, vascular invasion, et cetera.
Right. So, Dr. Hitesh, is there any situation where you would get a PET CT scan? That's something that's usually abused in our clinical setting because it's easy to get and it's cheap?
No, not usually as a diagnostic, because most of the patients who have HCC, they are not FDG avid. I mean, we do PET CT only in the setting of pre-transplant workup, the patients who are undergoing transplant as a protocol. But otherwise, for the diagnosis, PET CT doesn't have much role.
Great. I think a point well made. Dr. Soin, when is it that you would definitely do a biopsy before you proceeded on to treat that patient?
Whenever the diagnosis is not clear. So
what are those?
So if you have a situation where, so I must also add that we are using PIVCA2 or DCP quite often nowadays, along with alpha fetoprotein to corroborate or support diagnoses, and also as a prognostic marker. So we are using both AFP and PIVCA2. Of course, I agree with Amit that that's not the primary diagnostic criterion, but as a part of the workup and for future prognosis, we are using both these markers. Now, biopsy. Biopsy is obviously done if you're confused as to whether it's a benign lesion, if it doesn't have the typical early arterial enhancement and venous washout, and or if it only has like peripheral enhancement. So if you're in doubt about the diagnosis of malignancy versus benign, and then what kind of malignancy, if you're looking at HCC versus intrahepatic cholangiocarcinoma, then at that point, because their treatment management could be different. It could be the same. That means you could do resection for both, but then it could be different when you're considering transplantation, because transplantation is typically not considered for big IHCCs, whereas it is considered for HCCs, even if they're up to 6.5 centimeter. So that's when I would do a biopsy. But before the biopsy, I would do both axial imaging, that's CT scan if you've done an MR, and an MR if you've done a CT scan before that. Typically works for lesions less than 2 centimeter.
Right. So, so just to summarize that part of the discussion, if you ever want to pick up those small ones and treat and cure patients with HCC, I think you should have these patients with chronic liver disease on a proper surveillance program. That's the only way to pick them up early. The tests seem to be ultrasound plus minus an alpha fetoprotein, add on a better imaging MRI or a CT as you go by, contrast enhanced ultrasound depending on the situation. Frequency seems to be 3 months and a bigger imaging once every year. For the very small lesion, to delineate the lesion better, a contrast enhanced MRI seems to be the best way. But as the lesion gets bigger, there's not much difference between a CT and an MRI. Remember, at least for the medoncs who are listening, that you don't have to have an AFP in order to make a diagnosis of HCC, because that's what all of us are taught. As long as you have the characteristic imaging on the MR or a CT, that's good enough to make a diagnosis, irrespective of the AFP. People who don't have the typical imaging findings are the ones who need a biopsy. Not everybody needs a biopsy before proceeding on to the treatment. We will go on to the next part. Right. So this is another thing I wanted to ask the surgeons, because this is something that you may be able to tell us better. I'm going to show some slides as we go by. These were some slides where the Asia Pacific group got together and discussed a lot of things in relationship to management of hepatocellular carcinoma. And these are the discrepancies within the various groups. And let's discuss those discrepancies, because that will bring out the other points also. What is the relevance of measuring portal pressure or looking at indirect evidence of portal hypertension in a patient with hepatocellular carcinoma? Can I start with Dr. Soin again?
So, when you're looking at a patient with HCC, you have to look at 3 or 4 things. You have to look at what the primary disease is. If it is hepatitis B or C, has the viral replication been controlled? Then you have to look for the stage of chronic liver disease, if there is chronic liver disease. And you have to look at the fact whether the patient would merit a transplant from the disease severity point of view, not just HCC. And then you have to look at the HCC, the stage, the size, the number. You have to see what sort of AFP values you're talking about. And then you have to see its spread, whether it's spread extrahepatically or whether it is spread to the hepatic vessels. And these are all the things that you need to see. So as far as I'm concerned, staging of the tumor itself is only one part. You have to stage the patient. You have to also look at the performance status. So patient, liver, that's chronic liver disease, patient as in performance status, chronic liver disease, the extent of liver disease, the etiology, and the extent of cancer. All these have to be looked at staging, and that's how you decide on what treatment is ideal for the patient.
So you're saying as part of evaluation for the chronic liver disease, the portal pressure evaluation becomes important. Is that correct?
So the question on portal pressure is obviously if the patient has child's A cirrhosis or does not have chronic liver disease. So if the patient does not have chronic liver disease, the question of measuring portal pressure really is not relevant, because then they will have a normal platelet count and there'll be no features of portal hypertension on ultrasound and CT scan or MRI, whatever you've done. The spleen size will be normal, etc. There'll be no varices. So in that case, portal pressure measurement is not needed. But when there is chronic liver disease of, let's say, child's A or child's B, where you consider a liver resection for a small lesion ideally less than 3 centimeter or less, that's when portal pressure comes in. And typically we measure it by HVPG, hepatic vein pressure gradient, right? And if the HVPG is low, that means, some people take 8, some people take 10 as the cutoff value. Then you're looking at not much portal hypertension, and such a patient would withstand a major hepatectomy well. But if the portal pressure was high, then they would not withstand a major hepatectomy. They would still probably withstand a segmental resection or a minor resection, 2 segments or less.
Okay, so Dr. Amit, would you want to add on?
I agree with Dr. Swain. So really, as he said, portal pressure assessment comes in when you're considering resection as a treatment.
Correct.
And the degree of portal hypertension that you tolerate really does depend in terms of the extent of the surgical resection. The one minor difference is that there are some centers that do this invasively by a measurement of the HVPG, whereas others do it non-invasively. And at our center, as well as others in the US, we typically do this non-invasively, using some of the other things that Dr. Soin mentioned in terms of lack of varices, normal spleen size, and then we typically use platelet count. So if the platelet count is greater than 100, then we take that as a sign that there is not significant portal hypertension that would preclude surgical resection in those cases.
Right, so splenomegaly with the portal count of more than 100 means that the portal hypertension is not significant, but you could go ahead and measure the portal pressure to really get that value before you make any decisions. Right, yeah. So that's the relevance of measuring portal hypertension, whether the patient can undergo a major resection or not. Higher the pressure, less is the chance that he or she will be able to. So the medoncs in the group, please go away for your dinner. We will catch hold of you in the next 15 minutes, but please feel free to make a point in this discussion, because as I went through the literature and all the doubts that I had, I'm actually getting it cleared by the experts who are sitting here. So if you have some doubts, or if you want to raise a point, Anant and co, please put your hands up or start speaking. All of you are unmuted anyway. Right, so the BCLC staging system, the Barcelona Clinic staging system, is the one that is commonly used in order to make decisions. The 0, A, B, C, all of these are the, that's the way you go about staging your D, of course. That's the way you go about staging your hepatocellular carcinoma. Dr. Hitesh, are there other staging systems that are relevant from a surgical standpoint? Because for a medical oncologist, it looks like that's the best way to go. But what would you do as a surgeon over on top of the BCLC staging system?
Yeah, I mean, BCLC staging system looks a bit more conservative. If you see stage 0 and stage A, these patients, they are offered resection. But if you see the scenario in the Asian countries, I mean, the patients who don't have cirrhosis, because BCLC is mainly, for cirrhotic patients, and it has got limitations. So there are many patients who are actually going to benefit from resection beyond stage A. Maybe a few patients from stage B and C will actually qualify for surgical resection. So if you see stage B, the option here given here is TACE, and C is sorafenib or systemic therapy. But couple of patients, if you see, they will qualify for transplant, they will qualify for resection. So this criteria seems to be a bit more restrictive. There are a lot of other staging system from, Japan criteria, Hong Kong cancer staging system, CLIP classification from Italy, TNM, etc. So, but obviously BCLC is commonly followed everywhere, but it looks too conservative for surgeons.
Correct. I think the point is, yes, Dr. Bowman, please go ahead.
The intermediate, that is the stage B, I feel is a very heterogeneous group.
Yes.
Large multinodular does not mean much. What is the size? What is the extent of the disease? They have not given more details in large B, in the stage B intermediate. So I think that's a very heterogeneous group.
I think that point
Experts
is
can
very
answer.
Yes. So Viraj, how frequently have you seen somebody with intermediate and a performance status of 0?
That's right. Very, very good.
So, no, I don't remember that patient with intermediate and PS0.
Correct.
Because they do have some symptoms. But just going back to the further previous question about the intermediate B, I wanted to ask Dr. Soin and Dr. Amit Singhal.
Yes.
Based on Child and Milan criteria, there is a system which divides B into B1, B2, B3, B4. And typically B1 goes for resection and 3/4 go for systemic therapy. How often do we use this system in clinical practice?
So Dr. Soin and then Dr. Amit.
So while, the good part of the system is a bit of what I said earlier, that means it looks at the patient, looks at the liver, and then looks at the tumor. The bad part is, like Hitesh said, or let's say the shortcoming is that it excludes a lot of the patients who can have surgical resection and transplantation. So if you have a patient with child's puke C, with a 5 centimeter or even a 6 centimeter tumor, they're clearly transplantable, but they don't figure in stage 0 or stage A, or even stage B. So that's the problem. That's a shortcoming of the system that's been pointed out often. And that's why we don't strictly go by it. But of course, we've been seeing it, using it, talking about it for a long, long time. So we must understand that it's the stage of the liver disease, the patient, and the tumor that you have to look at, and don't really go by any particular given stage.
Absolutely.
It's not sacrosanct to say that B and C must lead to only sorafenib and TACE.
Absolutely. We'll come to that. Dr. Amit, and then we'll move on.
Yeah, I agree. So Viraj, you brought up this point, it's the B1, B2, B3, B4. And I think that, we're starting to actually use this more and more in clinical practice. So, in the US, downstaging criteria has now become standard. And so now people can actually get exception for transplant if they start with, intermediate stage tumors and get downstaged into Milan. And so I think, anyone who's being seen in a transplant center, that is the first and foremost therapy you think of when you see an early intermediate stage. And I think we've all come up with these different terms, early, intermediate, advanced, so I use B+, B-, almost like grade school in terms of grades. But these good Bs, you're right, we do local regional therapy with the idea of downstaging to get them to transplant. And now, as we'll talk about with IM Brave 150, I think that as we've shifted from TKI therapy to like checkpoint inhibitors, I think these more advanced intermediate stage patients, I can tell you in our center, we are sending them for systemic therapy now. And so these, large multifocal, multinodular tumors, I think that we have to understand that actually there's very little data for local regional therapy. The TACE trials actually largely included more early intermediate stage in their trials. And those patients are better evaluated in the systemic therapy trials, where you see about 15-20% of patients being in this BCLC-B category. So I think you're going to see a shift in clinical practice. And I think, but I mean, as many of us have already talked about, our job is not as easy as like, oh, you fall in the B category, let me follow the arrow down and I'm going to treat everyone with TACE. much more nuanced than that. We see them in
Absolutely.
clinical practice.
Absolutely. I think the point is
Dr.
well taken.
Sandil?
Yes,
Yeah.
Vamshi.
Yes. So since you are discussing the staging, I have had these patients who come with a localized disease, but there'll be a thrombus in the portal vein. And then there's always this discussion of whether it's a tumor thrombus, whether it's a bland thrombus, and what you do next. So it would be great if the experts can just tell us what we do in that situation.
Do you want me to?
Dr. Amit?
Anyone, please.
Dr. Amit.
Yeah, I can tell you when we see a patient who has a tumor and they see, a small thrombus in the portal vein, you're right that sometimes it's very obvious that it's tumor thrombus. Other times it can be quite difficult to tell, particularly when the thrombus is small and it doesn't have definite enhancement. It's not expansile. These characteristics that clearly would make you think tumor. And what we do is, we typically give the patient, quote unquote, the benefit of the doubt. So if there's no definite tumor thrombus, we treat them as having bland thrombus in that area, but then follow this. Now, if they have other signs like an AFP that's, 1,500 or 3,000, makes you a little bit more suspicious. But we will typically treat those patients with local regional therapy to start with, if they're otherwise a local regional therapy candidate, and then follow them. And I can say that even patients who have had small tumor thrombus, like just a branched tumor thrombus, we have had very good success either treating them with local regional therapy, TACE, TARE, or even resection in some of those patients if they're otherwise resectable. And that's, once again, I think where you see the BCLC start to fall apart a little bit in terms of you can have people with even a small tumor thrombus that do very well with local regional therapy or surgical resection.
Correct. So I think
I'd like to make a
Dr.
point
Soin.
Yeah. So, now portal vein tumor thrombosis is an evolving area, really, because typically what happens is that when you diagnose, we call it PVTT, portal vein tumor thrombus, when you diagnose a PVTT, you will typically say that they are not candidates for transplantation and they're not great candidates for resection. And like Amit said, some of them are good candidates for resection. What I want to do is go a step further and saying that we in our institute have actually been following a neoadjuvant kind of, not neoadjuvant, a downstaging protocol using TARE with SBRT, stereotactic body radiation therapy, for patients who have portal vein tumor thrombus and downstaging them to a point where the thrombus is no longer enhancing and no longer being picked up, no longer FDG avid on a PET scan. So that means the tumor thrombus becomes a bland thrombus. And then these patients, if they do not have extrahepatic disease, then they undergo transplantation. We've actually published this paper in Transplantation earlier this year on our experience. And these patients, this is obviously a select group of patients. This is not going to apply to everyone. Now, portal vein tumor thrombus is classified quickly into 4. VP4 is the main vein. VP3 is left or right. VP2 is for the second order branch. And VP1 is stuff that you may or may not even see on the radiology, but you only see on histology. And typically, VP1 may be there in many of the patients we operate on anyway. VP2 and VP3 are the ones that we like to downstage and proceed with transplantation. And about 70 to 80% of them are able to be downstaged, but we don't succeed in the remaining 30%. And in some of them, tumors progress, they become extrahepatic and all that. So this is not a write-off group straight away.
Yeah.
That's the current
So I think,
we're not alone here. There are AMC from Korea have published this, and at least 3 other centers have published these results. They are worse than non-portal vein tumor thrombus patients, but they're far better than anything else available, non-surgical or non-transplant.
Yeah, I think what we're seeing is that you can't just take a cross-sectional assessment of a patient. There's really a matter of tumor biology. Some of these are good actors and some of these are bad actors. And so I think we're becoming smarter about the way we treat HCC. Can I ask Dr. Soin just one quick question about your protocol? What's your typical waiting period before you would transplant somebody? How long do you want to see them have a response with no definite thrombus in the vein before you would feel comfortable transplanting them?
So typically, it's about 10 to 12 weeks. Because, we are in a living donor liver transplant situation. And we start to scan them typically at 6 weeks after they finish the downstaging therapy. And if the response is good, then we repeat scans at 8 weeks, 10 weeks. And if the third scan is good, then we just go ahead, because you can't be waiting very long when you've got a live donor transplant to do. Admittedly, if you wait longer and some of them will auto-select to recur, the other ones will do even better.
Yeah, because we've done select patients where we've downstaged them to transplant, but we typically wait longer. We typically, wait about 6 months, 9 months to make sure that we have a good effect. And the reason why I think this is important is because, once again, going back to the systemic therapy for the medical oncologists, I think we're going to see more and more responses. The data suggest you're going to see people who start with larger tumors. So you're going to see people with vascular invasion that are treated with systemic therapy that have a nice response. And so I think those people who are in med-onc practices, when you're treated with, atezo-bev or, other IOs, and you see these responses, I think it's important then to think about whether this patient could be a transplant candidate when they're downstaged, and to communicate with the transplant team accordingly.
Right. So I think we'll move on for want of time. So the point that the panelists are trying to make is that though BCLC is very widely used, prognosis and the outcome totally depends upon what you can do for these patients. And since our treatments are getting better, the transplantation criteria is getting a little wider, we've got better systemic therapies. So there can be cross migration of patients from one to the other. And this is grossly an inadequate classification, especially for surgeons, because they need much more in terms of the size and the anatomical characterization, the background, and so on and so forth, before they really decide upon what they want to do. For med-oncs, it seemed to be reasonably okay, because for us, if it's all over the place, it's all over the place. It can't be less than that. So we'll come to that a little later. Right. So let's come back to the case that we started with. Dr. Hitesh, what would you do for this patient?
I think so. He's not logged in.
Oh,
Yes.
he's not logged in? Or he's logged off? I thought he was there. No.
He's just logged off.
Okay, fine. Dr. Soin, what would be your choice of therapy for this patient? 46-year-old, no comorbidities, PS0, good liver, 3 centimeter.
Yeah, this is a straightforward case for segmental resection. It seems to be a segment 6 tumor, but I'd like to see the other axial cuts. And if it's involving the segment 7 as well, then of course, the treatment of choice might be a posterior sectorectomy. And if it's spilling over into segment 5, then a right hepatectomy. And of course, before that, one would assess the function and the volume of the remnant liver in case you're going in for a right hepatectomy.
Right. So it's a straightforward surgical candidate. If everything else is fine, is what you're saying. So what are your criteria for transplantation, Dr. Soin? Which patients go for transplant at your center?
Right. Okay. So the straightforward criteria are that we prefer to transplant patients who are obviously within UCSF, but we do not exclude patients who are outside UCSF. So we currently take all comers, any tumor size, any number, as long as they do not have extrahepatic mets, and if they don't have portal vein or hepatic vein tumor thrombus, and if they don't have extrahepatic lymph node, of course, lymph nodal spread is not acceptable. If they don't have all that, size and number is not a limiting criterion. However, what we do is now we look at AFP, we look at the total tumor size, and we try and we do neoadjuvant, not downstaging, but we do neoadjuvant therapy for patients who have high AFP beyond 1,000 and who are beyond UCSF. So those are the candidates we routinely accept. Then there is a select group of patients who have portal vein tumor thrombus, which I've already elaborated a couple of minutes ago, and we will put them through a downstaging protocol. Now, so these patients are patients with chronic liver disease.
Right.
Patients who do not have chronic liver disease will undergo resection. Patients who are less than 3 centimeter, who have Child's A, will also preferentially undergo resection.
Right. So what is that neoadjuvant therapy that you use if it's systemic therapy, Dr. Soin? Because you spoke clearly about radiotherapy, SBRT, but what is the systemic therapy? Because atezo-bev is something that's come up very recently, but before that, what is it that you were using?
No, so when I said neoadjuvant, I basically referred to TACE, transarterial chemoembolization.
Right. So it's not.
I didn't say chemo. I didn't say chemo or immuno.
Great. I'm glad you didn't say that.
Yeah.
Because we don't take great pride in talking about sorafenib anyway. All right. So that's what I think you made the criteria very simple. So there's nobody who's not a candidate as long as they don't have extrahepatic disease in any form, whether it's lymph nodes or visceral metastasis. If it's portal vein thrombus, you have your criteria to downstage and neoadjuvant or downstage, whatever that term is that you want to use, and then take them up for surgery.
So downstage is simple. Downstage is when you're actually looking at response evaluation after you've treated, And neoadjuvant is you give it and you operate anyway.
Oh, okay. So you've decided to operate. You just,
Yeah.
pulling that new adjuvant therapy. Okay, fine. That's another, new thing. Amit, Dr. Amit, what is it that you agree with Dr. Soin's criteria, or you have different criteria at your center?
Amit will not agree, and none of the Americans will agree.
I'm glad. So that's the reason behind this panel discussion. I want at some point in time people to disagree and start fighting.
Yeah.
It's so uneventful. People seem to be hungry.
Yeah, I think that, I think we know that transplant can be used for these patients with larger tumors. It's just that the survival and the recurrence rates are inferior to those patients within UCSF criteria. And I think, Dr. Soin already referenced that. I think the key thing is that in the US, if somebody's within UCSF criteria, you can downstage them into Milan, they get exception for transplant. So those patients that Dr. Soin is talking about that are outside of UCSF or outside of, UNOS downstaging, we do consider those patients for transplant on on a case-by-case basis, but it's largely, once again, as referenced, using living donor. Those patients are not eligible for exceptions, so they don't easily tap into the deceased donor pool. And so if those patients have a good response, so we don't do the neoadjuvant approach, we more so use the bridging approach. So if patients come in with larger tumor burden, have a good response, and are downstage, then we will consider them for living donor liver transplant on a case-by-case basis.
Right. So you stick to criteria, but here and there on a case-by-case basis, you're saying that it's okay for us to consider these patients for transplantation / resection after your TACE there, whatever you do to downstage your tumor. Dr. Vimal, can I bring you here? What are the situations where you would prefer to do RFA, thermal, or send it to the radiation doctor? Does the surgeon take the decision, or it's a multidisciplinary
It's
board as all of us?
multidiscipline, and the discussion with the surgeon definitely helps us. But as a radiologist, if I'm planning any of these ablative procedure, then size is definitely a criteria for us, especially with RFA. I mean, people are talking about even 7 centimeters, but if I have to do it, I don't go beyond 5 centimeters for sure, because I've not seen good results anything more than 5 centimeters. 3 centimeters and below, it's a good place to do an RFA or any of these thermal ablations. Another criteria obviously is the number of lesions that are there. More than 3 again becomes challenging. We may stage it over a period of time and then try and do multiple lesions. Up to 5 lesions is okay, we have done it. Third factor is obviously location of the lesion. Where is it located? Is it convenient to do this ablative procedure? You're not growing through the lung, you're not damaging the adjacent bowel or gallbladder. We may do hydrodissection in some of these cases. So these would be some of the criteria where we would do an ablative procedure. So localized lesions, well circumscribed, less than 3 centimeters ideal, or up to 5 centimeters maximum, and maximum 5 lesions that we have done. And anything more than that would be not an ideal situation. Involvement of portal vein and everything obviously is outside the thermal criteria, so we don't do them.
When would you say, send it off to stereotactic body radiotherapy and say that, I don't want to do RFA or thermal beyond your criteria that you've listed now? Obviously, more than 5 centimeters, yes.
Yes.
Something near your blood vessel or the gallbladder or the intestine,
Yes.
maybe SBRT is better compared to. So
That's
is there
right.
anything else? Okay, so if these are there and that's not a surgical candidate, then they go for SBRT.
SBRT.
Right. So I think we come to the end of our first case, wherein if surgery is possible, surgery is the best. Look at the possibility of liver transplantation. If that patient fits into that criteria, you use all the methods to downstage and take them to surgery. If they are not a surgical candidate, then you always have all those non-surgical interventional radiology-based treatment which are available. Size, number, and anatomical location, all the 3 are important in a situation like that. So we will move on to our second case. This is a 60-year-old male who presented to gastroenterology with right, abdominal pain, upper right quadrant. He's got a history of diabetes, hypertension that is controlled with ramipril, chronic hepatitis B treated earlier, as always in our setting, no records and no further follow-up. ECOG performance status is 0. Her upper gastrointestinal endoscopy showed esophageal varices. His alpha fetoprotein was 1452, Child-Pugh A and BCLCA. This is his imaging. It's a large solitary tumor, Child-Pugh A. there's no vascular invasion. So what shall we do for this patient? Are the surgeons around? Is Dr. Soin around? Or he has left because he wanted to leave early?
Another call.
Okay, he's on another call. So Dr. Amit, what would be your approach to a patient who's got a large tumor like this, confined to the right lobe? There's no evidence of metastasis. There's no lymph node involvement. There's no vascular involvement. What would you do?
Yeah, so I think, you said that the patient had known varices, so the patient has portal hypertension.
Yes.
Given the size of the tumor, the extent of the surgical resection that would be necessary, this is not somebody that we would feel comfortable proceeding with surgery in this case. But, if the patient had not had portal hypertension, despite the size, we would have to see the future liver remnant. But this is somebody, even though it's a large tumor, if the patient did not have portal hypertension, we would at least evaluate them for resection. In this patient, given the portal hypertension, we would use local regional therapy, with chemoembolization, radioembolization. And so at least in our center, we would likely, given the size, do radioembolization as the upfront therapy. We tend to see some nice results in some selected large tumors like this, but I think you'll get a better sense of tumor biology. I'm going to also say that, if this is somebody where if we treat with local regional therapy and we do not see a good response, we would have a lower bar now to then shift to systemic therapy. We would not keep, hammering away with local regional therapy if the response was suboptimal.
If the local regional therapy was suboptimal response and this patient still had a big tumor not amenable to resection, would this patient be a candidate for transplantation? Chronic hepatitis B, though we don't know the activity at this point in time, has portal hypertension, especially with the points that were made earlier that if the portal pressure is high, may not be a good candidate for resection. So is this a patient who should have tear, as you said? We'll come to that a little later, and then get on to transplantation, or would you plan a resection?
Yeah, this is somebody that if they had, a good response to local regional therapy, so if we treated with radioembolization and the tumor biology appeared favorable, i.e. a response to local regional therapy, this is somebody that we would then evaluate for transplant, understanding that given the fact that they appear to be outside of downstaging, this would have to be a living donor liver transplant. They would not be eligible for exception points via the UNOS system. So if the response was favorable, you're right that we would consider downstaging and listing for transplant. If the response was unfavorable, then we may consider shifting to systemic therapy.
Yes, Dr. Vimal, I want you to I want you to make a point, and then also the question that I wanted to ask is, there's always this confusion, at least among the medical community, as to what should come first, TACE or TARE, because many of these, algorithms that you see, especially based on the BCLC, tells you that TACE comes first, and then if TACE failures or some selected cases, TARE comes in. I want you to also answer that question. Do you strictly follow that algorithm, or you don't?
No, so we would love to follow the algorithm, and as Dr. Amit said, that we would prefer to do TARE in all these patients, but quite a few of our patients cannot afford it. So if I don't take the economics in it, then obviously TARE is a good method now. It has been.
So if I can interrupt you for a moment, sorry to interrupt. So why is it that the guidelines then don't recommend TARE as the first option? Because if there is good scientific evidence, and in the West at least everything is provided for by the system, why is it that still the guidelines don't say TARE and they say TACE failures go for TARE?
So, I don't think so that has got clarified 100%. There are few articles that have come up that the TARE, the acceptance is much better. The overall outcome of TARE and TACE is more or less the same. But the patient response and patient outcome, in the sense, patient accepting the treatment, TARE is much more safer, and the toxicity and all are much less. So from that angle, probably TARE definitely proves better. Nowadays, some papers have come up and they said that the outcome of TARE, as far as controlling the tumor or downsizing it, is much better with TARE. So therefore, there's still, it's not clear cut on that.
So Amit, what would you do? Because your insurance coverage will question you if you're not going through the algorithm. So how is it that you justify this?
So a couple of things. The first, I'll answer the question in terms of, so I agree that, the data suggests that radioembolization appears to be better. appears to be better tolerated than chemoembolization, although the overall survival, we don't have any data that suggests that the two are different. There are data out of Northwestern and some other centers that suggest time to progression may be better with radioembolization, although most of the data are retrospective cohort studies. There's very few randomized data, and that's really why it hasn't been built into the guidelines, is that there's very few randomized data supporting radioembolization or evaluating radioembolization. So I think that, I think the guidelines are really based on the level of evidence rather than what we see in clinical practice. That being said, just because it isn't built into the guidelines doesn't mean that we don't have insurance coverage for it. And so most insurance coverages will continue to cover radioembolization given the extent of retrospective data that has shown good results.
All right, so if we decided to do TACE, do you see any difference between the ones that I've listed here, just the TAE, the TACE, the DEP TACE? Is there any difference between any one of these? Because the literature does not really say so. So what's your thought?
I think DEP TACE is a little bit better tolerated than traditional chemoembolization, although we don't see any definite data saying that one has better efficacy than the other. I think once again, it goes to patient AEs and patient tolerance. I'd love to hear what others think.
Yeah, so basically,
Dr. Vimal,
the DEP TACE, the particle size are much smaller, and therefore you get deep penetration, and the overall outcome is much better. The only problem with DEP TACE is quite a few patients do develop a post-embolization syndrome. And another issue is that we tend to see some patients who develop infection or abscesses within this DEP TACE, especially if there is some amount of necrosis of the biliary radicals, then you tend to see some necrosis with DEP TACE because there's a deeper penetration of these particles, and there's post-embolization is much higher.
So when you say that you see more, you think you see more abscesses than traditional chemoembolization with DEP TACE?
Yes. So with DEP TACE, you tend to see more of these abscesses formation.
Okay, that's interesting because we don't see that in our site, but it may just be differences in patient characteristics.
There is some underlying infection still existing, or something is there with our patients. We say this.
Yeah. I just wonder if it's a different in patient selection between the two. I mean, patient characteristics between the two countries.
All right, so these are some things that we have already discussed, so I'm just trying to go forward. So the point on those slides where that you need to make your appropriate choice in terms of who you want to do your TACE or any transarterial therapy. There are standard contraindications that we have to look at, but as was discussed again, all of these are subjective and you have to make a decision patient by patient. So for that patient, ideally tear followed by downstaging and then resection. If resection is not possible for whatever reason, consider for a transplant on a case-by-case basis. If that's not possible and the tumor increases again, then probably systemic therapy, because there's no role for combining systemic therapies along with local regional therapies, at least
Dr.
based on.
Sandal, if I could just ask a doubt on the previous one.
Yes, I mean, yes, Anant.
Yeah. So now that you have data from the tactics which combine TACE plus sorafenib in exactly those patients who underwent TACE, your thoughts, anyone's thoughts on that, because that was a doubling of PFS seen in that study.
Yes, the only study that probably showed some benefits.
Yeah, but it was a doubling, so
Okay, so Dr. Amit, would you like to take that, or in this era where you got some better systemic therapies, again that would be under question. Is that what you would think, Dr. Amit?
Yeah, no, I agree with that. I think that the tactics trial, while it was positive, I think that when you take a look at the entire literature around this, we have many other, RCTs, TACE2 space, et cetera, that failed to show a benefit of TKI therapy when combined with local regional therapy. And then, as mentioned, we've now shifted in terms of, largely saying that there are better therapies than TKI in terms of the front line. And so I can say at our center, we don't typically combine LRT with systemic therapy at this time outside of a clinical trial. I do think that is where the future is going. I think that, there are many phase 2 studies that are combining checkpoint inhibitors with local regional therapy, whether that's radioembolization, chemoembolization, et cetera. And I am optimistic about those studies. But, in terms of tactics, I think it was a nice study. I think it was designed a little bit different than the other two. But I still think that it's, a little bit too little, too late. type thing to
Yeah,
save that.
It was a nice study because they were actually able to deliver the appropriate amounts of TACE, which was something that the other trials were not able to do. And once in that setting, they showed a PFS. It's interesting to use it. They designed it very well and were able to give at least 3 to 4 TACEs per patient. And then
because they had the different outcome of untasteable disease rather than just progression. And so I agree with you that it was probably a little bit more parallel with how some centers practice in terms of their TACE delivery. But once again, I think that the issue is that the field has now moved on beyond, where, when that trial was done.
All right, so we'll go to our case 3 so that we pull in our medical oncologists and talk about a little bit of systemic therapy. 70-year-old non-cirrhotic liver, pain-ripe hypochondrium and epigastrium, performance status 1, multifocal or hepatocellular carcinoma with intrahepatic metastasis, Child-Pugh A, BCLC-B as per the staging system. So we have discussed a bit of TACE and TARE here, so we need to look at those options. Dr. Hitesh, you're back. Are there patients with BCLC-B who can go for surgery, and you will say that the options are better than TACE?
Yes, I just missed out the previous case discussion.
Yes, so that's a chance for you to.
Yeah, so I just saw the slide. There was a large HCC with a very good liver on the left side. So I was just thinking, looking at the patient, see the performance status, LFT, everything. Maybe we can have a thought on upfront surgery, because it is a large tumor. If we have to do preoperative proper evaluation, volumetry, I could see that there was a very large left lobe, and just a thought of upfront surgery, because the other modalities are not going to be that much useful in that case. It's a huge HCC. To downsize is not that easy.
You're right.
So we do find such patients who are BCLC B and C, but this case 3 that you have showed, it looks multicentric, and
that's correct.
Probably will go for locoregional therapy and maybe combine some systemic therapy.
Absolutely, that's exactly what our panelists also decided. Some downstaging therapy followed by surgery upfront, transplantation. Getting the tumor out is the best thing to do, nothing like it. So we'll go to our case 4, 45-year-old chronic liver disease, hepatitis C on interferon and ribavirin, which was stopped a year ago. There's no history of a variceal bleed, investigated for recent weight loss and abdominal distension, pain, no other comorbidities, PS2, AFP 2685, Child-Pugh B7, BCLC-C, and that is the imaging, tumor all over the place, right? Symptomatic performance status to BCLC B7. So Viraj, what shall we do?
So this patient, BCLC-C, will go with systemic therapy straight away.
Right.
Discuss the options. The current options are TKI versus IO plus any VEGF agent, like pembrolizumab versus atezo-bev. So in India, depending upon the cost, we will move forward.
So what would be your choice? Anil Ambani is your patient. He doesn't have money now, looks like, isn't it? So let's not take Anil Ambani. Let's say somebody else who is richer than him.
So if there is no logistic issues, I would go with atezo-bev, especially when variceal bleeding history. I would not be worried about the bev part. So it will be IO plus bev. And I have 3 patients who are other IO plus bev, because atezo is very expensive in our country. So I have using IO plus bev.
So you're saying you would use pembro plus len in that patient, in that kind of a patient who cannot take atezo.
Customize it to nivo plus bev.
Nivo plus bev, but nivo has been a disappointment in the first line, isn't it, Viraj? So how would you really substantiate your choice of nivo? I mean, there are people who believe that all the IOs are the same. There are people who believe it's different, and the trials actually made the difference. So how would you substantiate use of nivo? I thought pembro-len might be a better choice, but why would you use nivo?
So checkmate 459, which was slightly a negative study because of a statistical error from the sponsors itself. And it was
Viraj, at the end of the day, we will read the trial for the outcome. There are so many trials where we all think there might have been errors, and and that's the reason why would or would not. But I think I'm a little skeptical about your choice of Nivo. But if you still want to use it, and go that way, because I put up that trial on your screen. It's 0.07. Dr. Amit, would you like to comment? Viraj wants to use Nivo plus Bev. What would you think?
So a couple of things. The first is, taking a look at this patient, I think it's important to note that they were a child B.
Yes.
And so the one thing is that, the atezo-bev was evaluated obviously in child A. They required an EGD, good control of the varices, et cetera. We don't have data in terms of the safety of atezo-bev in a child B. And, theoretically, the risk of bleeding may be higher in a child B, even though they're a child B7. And so I do think that, that would have to be entered into with some thought in terms of using it in this specific case of a child B7. Outside of that, I mean, going back to your question of, can we substitute, one agent for another? Can we use Nivo-bev instead of atezo-bev? I don't think we know, but I will say that my personal thought is that there is very little difference between these agents. So whether you use Pembro-bev, atezo-bev, Nivo-bev, I don't think there's much difference. So I actually, if I had to say, like, which side am I on, quote unquote, I'm going to be on Viraj's side, that I think that you're probably fine here. I think the reason why it was assigned as atezo-bev, I think the reason why it was assigned as atezo-bev is because they're both from the same company, right? So
I understand.
It was easy from that standpoint, but I don't think that we know that there's any difference between substituting out one PD-1 versus another. So I think it's probably fine, particularly when you take a look that patients are paying out of pocket. I think we do have to be cognizant of financial toxicity of the therapies we're choosing. So
okay,
Dr.
Yeah. The patient is PS2 and B7.
Yes.
Within the confines of us wanting to treat.
Yes.
This patient has a median survival expected of 4 to 5 months.
Absolutely. So that's why I put up this patient, because this is a patient that was never in any of those studies.
Yeah, I mean, it would be a task treating this patient 1.
Yes.
Then treating with a doublet 2.
Correct.
It would be very difficult to treat this patient.
And Anand,
I agree, and that's why I made my point initially that the question is whether you treat the patient with anything, or the question is whether you treat with a doublet, like you said. I think there are concerns about safety, and I think that you're right that there's concerns that whether this would make a difference when somebody's PS2.
Yeah.
Correct, because it's much more difficult to use lenvatinib and sorafenib in this patient than you would find atezo-bev, isn't it? So, and the reason why I put up a case like this is the typical HCC that all of us see in our day-to-day practice. Though we'd all love to see patients who are performance status 0 or 1 with an AFP of 200 and child PUX A, but that's typically not the HCC that we see in our practice, and that's why I brought up this case for discussion. We all understand that doesn't fit into the inclusion criteria of a trial. Please go ahead.
Yeah, I mean, my basic thing was that I would like to give him some treatment, and the best possible treatment would be probably one of the immunotherapy agents.
Yes.
A combination to me would not appear feasible with this patient.
Okay.
And specifically off trial indications, because PS2, B7, as you said, don't come under. So then, and as Dr. Amit said, I think largely the immunodrugs behave similarly. So, as Viraj had said, Nivo or, one of those drugs. But it would be a task treating this guy and expecting outcomes.
Absolutely. Vamshi, you wanted to make a point.
But no, Anand, I agree with this point that all the drugs are similar, but you have 2 agents which have not worked. You have Pembro didn't really work in the first line, Nivo didn't work in the first line, and saying that atezo-bev works, so let's just combine the 2 is difficult. At the same time, 2 drugs which have not worked, you say that I can't do anything else, let me just give one immuno because something has worked. I mean, it's difficult.
It's same, but it's not similar. That's what Vamsi is all about. Dr. Bowman, you're the senior most. You're the senior most, so I give you the final say on whether all of them are the same or not.
No, they are not the same. I don't think so, because one is PD-1 and another one is PDL-1.
Okay.
So you if you say all TKIs are same, like sorafenib, lenvatinib, do you say they are same?
No, sorafenib and regorafenib are the same. It looks like. But they continue to work.
So they all are TKIs. So one is PD-1 and one is PDL-1.
Okay.
They are different group of drugs. And we know from our experience in other malignancies that in lung cancer or anything, PDL-1 are different and PD-1 are different. So it's very difficult to generalize.
Yeah, I think this is an argument that goes on in so many of our forums, whether the trial made the difference or the drug made the difference. But I think nobody knows the correct answer to that question. But, you know, as much as possible, we'd like to stick to the trial combinations rather than break them apart unless there's an absolute need to do that. Dr. Amit, I want you to comment on this. Yes, we've seen some better responses, nearing 30% with the combination, in some criteria going up to 40%. But is this correct, the slide that was used by the discussant at the ESMO Asia, because of 8-month follow-up and showing a hazard ratio of, you know, somewhere around 0.6 or 0.5, but with a longer follow-up, that's likely to come down is what people think. What are your comments on that?
Yeah, I think that's you know, very possible. I think that we'll have to see. I mean, obviously, you know, right now we have early data, and like you're saying, we'll need to have continued follow-up to see if these results hold true. I think we have to remember that the stopping rules are established in such a way that we don't think that this is going to be a lack of significant difference. It's just a matter of where that point estimate becomes in terms of the degree of improvement. So I do think that atezo-bev is an improvement over TKI therapy. It's just a matter of exactly the point estimate for the hazard ratio.
Absolutely, I think that point. Yeah, please go ahead. Completely, please.
And then I was just going to follow up on the prior conversation in terms of saying that you know, checkmate 459 was negative, which I agree it was negative. But when you take a look at atezo-bev versus, you know, nivo, we have to remember nivo was monotherapy. And so I do agree that there's differences between PD-1, PD-L1, but I think the big thing that we're seeing in terms of the advancements are combos. That checkpoint inhibitors in terms of HCC are probably not sufficient when used in isolation. But when you take a look at all of the combo trials, whether it's atezo-bev, len-pem, or, you know, IO plus CTLA-4, they're all showing, you know, very promising data moving forward. And I think what we're seeing is HCC is a difficult disease, and we probably need combo therapies to really move forward and improve survival. So that's why I was saying, I mean, by no stretch was I saying that we should do this routinely in terms of like saying we should use nivo-bev, but it was more so in a patient who can't afford atezo-bev.
Yes.
You know,
so
in terms of the other alternative, I think, you know, using nivo-bev for financial toxicity is reasonable.
I understand. And then the IO is coming up.
Yeah. One last point to Anand's point in terms of the child B. I would say that, you know, the two agents that we have data in terms of child B, just at least at this point, we have some data for sorafenib, you know, with the real world data, and then we have data for nivo. Nivo monotherapy in child B. Once again, small numbers, but from checkmate 40, we have some data in terms of nivo tolerance in child B. So when you're taking a look at those patients you're seeing in clinical practice, I think we all do things off the books sometimes in terms of outside of clinical trials because we have to. Not everyone fits in a clinical trial. But when you want to say, I want to be on solid ground in terms of having some clinical data in a child B, those are the two agents that we have data in terms of a child B, and then you can always go from there.
Absolutely. And in fact, nivo, if you want to, you know, Viraj, nivo probably had the best survivals before atezo-bev. You know, though the atezo-bev, the data is not reported yet, the median survival is not reached. Before that, it was nivo that had the best data. Viraj and then Anant, I want you to comment on what's there on the left side of this slide. Lower dose bev or a biosimilar bev. Viraj and then Anant. 15 milligrams per kg, 7.5 per kg.
So honestly, the 3 patients that I've used is 7.5.
7.5. So you believe that? Okay. I do those. So go ahead. Again, for cost considerations.
Biosimilar, especially in India, when they are so cheap available.
Very good.
It's very easy decision for me.
Anant, you agree with that? Is that what you do? That's what I do.
Yeah, for sure. The PK/PD for BEV is not like standard chemo.
Absolutely.
I'm sure if you had a trial for much lower doses, it would work just as well. And we've seen that in colon as well. You know, you can use anything from 7.5 to 15. So I think that's a fair way to go.
Great. Vamsi, you would agree with that?
With this question, yes, I agree. Your 7.5 is probably good enough. I am kind of a little not very on board with this whole onboarding the PK, the PDL1, PD1 in the first line in this way.
I think
the benefit is not so huge. No, the benefit is just, you know, 1 month in PFS, a couple of months so far. We don't even have long-term follow-up, and then pushing it into the first line and giving the impression that, you know, that is the way to go. I don't think the benefits are as great as we have seen in a lung or in any other malignancy for that fact.
Anant, you wanted to say something?
Yeah, so Dr. Vamshi, in that exact patients that was discussed, PS2 with B7, would you give a TKI or would you give single agent immuno?
I would offer best supportive care as the first option.
I agree.
That's the first option.
If you decided to treat.
So again, Vanant, the question is not that what we can do. We can do a lot of things by twisting data, but the impression should not go that that is the standard of care, which our discussion seems to be going around in that way that, immunotherapy has made a huge revolution in HCC. It is not that case. It is definitely probably better than what we have now. But I think we need to wait some time before declaring Atezo-Bev as an undisputed champion in HCC. I mean, just a personal thought.
No, you are absolutely, your point is well taken, Vamsi. It's just that at this point in time, it seems to be there. And I think the other point that we have not discussed so far is in terms of tolerance.
Yes.
Nobody likes sorafenib, right? You have used it, I've used it. Rarely have I been able to go beyond 400. Lenvatinib, the moment you put them on the doses that are required, for some reason, patients with liver cancer don't tolerate it as well as patients with thyroid cancer. Right, you put them on 12 milligrams, they're back with you in 1 week with either blood pressure that's going up or a PPD. So I think the point is also from the fact that we've had therapies that were so ineffective and so bad in terms of adverse events, and then you find something like this coming, it looks like a honeymoon, but like any other honeymoon, that also comes to an end at some point in time. So let's wait and see. So that brings us to this point. Viraj, tomorrow, if lenvatinib pembro is up there, who would be your candidate for lenvatinib pembro?
So lenvatinib and pembro, we know, have been very toxic when combined. The grade 3-4 toxicities up to 1/3 patients. So if I have to combine a VEGF and an IO, I would be more comfortable with Bev as a partner rather than lenvatinib. And
Dr. Bowman, lenvatinib pembro, if that's available tomorrow.
The toxicity would be my concern, actually. Correct. Absolutely. Okay. The toxicity would be my concern. So for a very fit patient, child pug A, maybe. But otherwise, I do agree with Viraj that bevacizumab will be a very soft partner.
Correct. We are all happy with the partners and we are talking about honeymoons. I think that makes a lot of sense. Very good. Excellent. So let's come to reality now. Most of our patients don't get Atezo-Bev. So leaving aside that patient, let's say somebody was suitable for sorafenib or lenvatinib. Anant, what would be your choice?
So my experience with lenvatinib is a little limited because of the kind of patients I see. But the few patients I've given it to, they have tolerated it very well. Much better than experience with sorafenib, for sure. Much better. You tell them to monitor BP at home and just treat the BP. They tolerate it much better.
Absolutely. So is this a concern, Vamsi, since you're sticking to trial criteria most of the time? I know you also use lenvatinib, but look at this. In the lenvatinib trial, all these patients were actually excluded. Patients who were PS2, there was some PS2 in sorafenib, big tumors, bile duct invasion, portal vein invasion. These were all patients who were not on the lenvatinib. So do you really look into these criteria, or you're like me, it's just lenvatinib versus sorafenib, I'm not going to the nitty-gritty of it?
I would not really look into this nitty-gritty and say that these patients I will not use lenvatinib. Because again, like Anand says, my personal experience with lenvatinib has been far better than with sorafenib. Again, in terms of tolerance, it is much easier. 12 milligram, I usually don't go up to. 8 milligram is pretty well tolerated.
Absolutely, point well taken.
Yeah, agreed. So, yeah.
Correct. So I think Dr. Bowman, your thoughts on that?
Yeah, I do agree that lenvatinib, in fact, my experience recently has been much more on lenvatinib than sorafenib.
Yes.
And few of my patients on whom I have given lenvatinib, and then I had given one patient SVRT for the portal vein thrombus, and I had used it and put that patient nearly went to complete remission, and means the tumor could not be seen at all on the scan, and now they are thinking of a transplant in that patient.
Great. So Viraj, does this make any difference? What I'm showing on the screen, that the background liver disease might also impact the outcome with these drugs. So let's say somebody who's got hepatitis C. Would you be tempted to use sorafenib in them rather than lenvatinib? Or you would say all that doesn't matter?
So we have clear evidence that in hepatitis C, sorafenib is much better efficacy-wise. I was not sure we have a data on lenvatinib. Was the previous slide on lenvatinib HCC?
Yes, it's a comparison. It's a comparison.
Okay.
So that's the comparison on the PROTECT or the REFLECT, sorry, the REFLECT study.
Right. So I always thought that when they did a subgroup analysis of HCV in lenvatinib, they would do well as well. So great. So that would not be my way of selecting. My preference is lenvatinib as TKI. 8
Okay,
milligrams.
Anant, any thoughts on that?
We know that Hep C, chronic Hep C with advanced HCC does better than HCC with Hep B. This was seen in the sorafenib trials, and that's the only thing I would use, that Hep C does better than Hep B. I mean, that's all. But I would
Hep
not
C
use
does
it to
better
select.
than. So you're saying it's just prognostic, it's not predictive.
Yeah.
Viraj, hepatitis patients, or rather HCV, HBV, seem to be doing much better in all trials, and also seem to be doing much better with immune checkpoint inhibitors also. Do you think there's something immunogenic in these patients, or what do you think is the reason? Is it again just prognostic, or do you think it's predictive?
I don't think it is predictive. HCV cirrhosis is better. We know that as a prognostic indicator.
Right. So I've just left this slide vacant because I don't know what to do in this setting. Does anybody here have any experience? Post-liver transplant hepatocellular carcinoma cannot be resurgery, it cannot be RFA, it cannot be SBRT. Ultimately, they end up with us with 3 bone metastasis. You know, I really don't know what to do. What is it that you do? All of you, what would you do? Just
I had 3 such patients. And none of them did well.
So in your vast experience, of 3 patients, all of them did poorly. Viraj, what is your thought?
No, I know we cannot do IO in this patient. I know we cannot do the loco-regional therapies. Unless there is a small recurrence in intra-liver, you could consider for resection. But if there is an extrahepatic disease, I think so TKI is the only way to go.
Right. Dr. Bowman?
The data right now is only for sorafenib, because sorafenib with immunosuppressive drugs are better tolerated, and there is no data for lenvatinib. So, but data is there for sorafenib only post-transplant.
That's right. So, and we would not use immune checkpoint inhibitors in a post-transplant setting.
Yes, I've given 4 patients post-transplant recurrence immuno with full explanation. 3 of them were doctors.
Okay. Oh, okay.
3 of them were doctors. And 2 of them have crossed 1.5 years with no issues of tolerance.
Brilliant.
I went and looked back at retrospective data, and there are small case series of nivolumab, used post recurrence, and they've also had a heads or tails response. So irrespective of what we intuitively think that on suppression you possibly should not use, there's something else at work.
I know. Okay, so that's a good point. So that you if you're in a desperate situation, then you don't have a choice. I think you need to take this decision case by case, explain to your patient, and go ahead and do it, is what I think. I'm happy you brought up that, because none of us have any experience in that setting at all. So these are second line drugs. How many patients of yours really get into second line, Viraj?
I would say less than 30-40%.
Less than 30%. Vamshi?
Yes, around that.
Around that. So regorafenib. Anant, are you a fan of regorafenib? Are you a fan of regorafenib?
At 80 milligram as a stabilizing agent, yes. Otherwise, no.
Otherwise, no. Dr. Bowman?
I totally agree. Regorafenib dose modification, like the redose trial in colon.
Right.
Somebody should do it like here also.
Viraj, you specifically wanted me to discuss this. I like this. I like to read this. But then, why did the drug work, Viraj?
No,
So these were all post-sorafenib patients, isn't it?
Right.
We wouldn't expect it to work, but it did work. So I don't know. In theory, it seems to be that it won't, but in reality, the trial was positive, and it seems to be, in terms of the numbers, the drug that has the best numbers looks to be regorafenib, at least in that clinical setting.
So the problem with this study was the patients who had to come on this study had to have benefit for at least 9 months on sorafenib. Okay. And if you see the control arm on placebo, the median survival is 8-something months. So I don't have any patient like this. I have not seen such a hepatitis HCC patient. So this is not representation of what we see in clinical practice.
You rarely see a sorafenib patient who's gone on for 9 months, is your point.
Yeah. So and then with the on placebo lives for median of 8 months. So correct. I don't know where is this patient.
Absolutely. I think your point is well taken and rightly made. What about immuno-oncology drugs in the second line, Vamshi? Pembro was a negative study.
So for me, Nivo is something that I have been using again in a few patients, but poor, not really great results.
Again, typically a setting where Pembro failed, Nivo, there's just phase 2 data showing that the outcome is good. What are your, Anant, you are looking forward to Nivo plus EP in the second line, just in case you didn't use IO in the first line. This data looks much better than all that we have so far. Those smaller numbers of patients, what are your thoughts?
In the phase 2 study of Nivo in sorafenib, treated patients, the survival was 15 months. Yeah. And I think sorafenib naive was 28 months, which is unheard of in HCC. Based on that, we used Nivo extensively in second line. And one, the tolerance is great. And we've actually seen good outcomes. Again, this would be 10, 12, 15 patients. But I like the drug in the second line for sure. The combination, I've had very limited experience. And EP was not easily tolerable in the one odd patient I've used. So I really don't know.
Dr. Bowman, any experience in that setting?
So Nivo plus IPO I have not used.
Right. So I think the choice of an immuno-oncology drug for everybody in the second line seems to be Nivo, all the more because the Pembro study actually failed. So I am done with my discussion, Viraj. So, just to summarize all that we have learned today, I think the bottom line is that these stages are not watertight compartments. Depending on your ability to downstage and operate, downstage and transplant, please do not forget to get the other specialists on board before you treat your patients with hepatocellular carcinoma. That may be the surgeon, the interventional radiologist. We discussed about the role of the radiation oncologist. When it comes to systemic therapy, looks like that the IO plus anti-VEGF combination seems to be taking the cake at this point in time because it's better in terms of response, it's better in terms of progression-free survival, certainly in terms of tolerance. So that seems to be the best at this point in time. But as was rightly pointed out by all of our experts, we need to wait for longer time to see that the data is much more robust and we get the same survival benefits as we have now, and that stands the test of time. Second line, nobody is very enthusiastic. Not too many of their patients go into second line, but if you go into second line, it looks like Nivo seems to be the drug of choice for all of them. So with that, I will hand it over back to Viraj, and if there are any questions that you want to take, please go ahead, Viraj. Thank you so much, all the panelists. Thank you so much.
Thank you, sir, and all the panelists. I think so. We have shooted way over time, and there are few questions. There are 230 people watching us, but just one question for Dr. Vimal Someshwar. How about SBRT cyber knife as a neoadjuvant strategy? This is from Dr. Sridhar in Bangalore. And I think so, there are a lot of questions, but I think so we'll just take one and close it, I think so. So, interesting, so I thought I'll ask you.
SBRT is really coming up very strongly in this area. And especially the areas where we have failed or our results have not been good, or we felt in a case where we could not do either TACE or TARE. These are the patients subjected to SBRT. And as I look at it, the future in SBRT is definitely positive. And probably in future, we may do more of SBRT than even interventional procedures. So looks very positive, but again, very limited.
What is cyber knife and SBRT?
No, I won't know much because I don't get involved. I'm not involved, but how is it different? I don't know. But as I see it, SBRT is probably one of the promising area. Yeah.
The proton beam is also coming up in a big way.
Yes, proton beam is also coming up.
I will not use.
Amshi sir is laughing. Sir, you have any comment?
I am not a radiation oncologist, but as far as I can understand, all of it is just radiation. CyberKnife or any other machine is just a machine. Ultimately, it's the ergonomics of it, it's the delivery of it, and that changes. The actual radiation you're giving does not change depending on the machine you're giving. Except for proton.
It's getting more and more focused. More and
it
more.
Doesn't matter if you're. It doesn't matter what you use. Ultimately, the radiation matters. The conformation matters. So I think that's really just a.
I would just like to add that. Previously when we were taught, RT was liver was considered a radio-resistant tumor, right? Yes. So the thing with SBRT is its applicability. It can be used in almost any setting. You have tumor, you have a portal vein thrombus, you can use it. You have a large tumor, you can use it. So its applicability is very is much more now compared to previous EBRT. The data is not there. The data is not there.
So again, Anand, the larger tumors do not actually get SBRT in the traditional 1 to 3 fractions. Larger the tumor, you need to hypofraction it. You need to give in 5 to 10 fractions. So logically, yes, it works. But as you said, we don't have the data. And proton is one more method, but proton is something that might come in because that's giving a different radiation, it's giving different side effects. So again, I'm not a radiation oncologist, but that's how my take.
Great. That was a fantastic discussion. And thank you, Senthil sir, once again for doing this wonderful moderation. And thank all the panelists. For all the viewers, I would say if on demand, you could ask recording of this and we will give you within 2 weeks. With this, good night, everyone, and take care. Thank you very much, all of you.
Thank you.
Thank you, Viraj. Bye-bye.
Thanks, Viraj.
Bye. Thanks for calling us.
Bye.
Thank you for calling
Thank you.
us.